I'm Pastor Jeffrey Phillips, Associate Pastor at Winnetka Congregational Church. We welcome you to this Care and Calling Ministry continuing education event on memory loss and caring for people with memory loss and dementia. Care and Calling is our church's lay caregiving program, church members caring for church members. I know you think that we pastors can do it all. And I hope we never think we can do it all. We need help from our church members. When those of you who are trained Care and Calling ministers were trained, Carol Jansen and I promised you continuing education opportunities, and this event is one of those. I think this program on memory loss and caring for people with memory loss is important because it leads us in many important directions, many helpful directions. As a pastor and a resident theologian, I think it raises a very important question. What does it mean to be a human being? In the West, we suffer from Descartes' all-imposing quote, "I think, therefore I am." Well, what happens when our thinking ability, our cognitive functioning declines? Are we no more? If so, then we don't have to have the same kind of regard and care for people who have memory loss as for those who don't. I think we need to challenge that Cartesian philosophy that says, "I think, therefore I am," and say, no matter what your cognitive functioning from birth until death, you are a human being who has a unique nature and spiritual needs, physical needs, emotional needs, just like anybody else. Which means that no matter what your cognitive functioning is, was, or will be, you deserve love, care, and compassion, just like any other human being. I also note as a pastor that I've heard this a lot, maybe you've heard it too. People will say, "I can handle getting old. Physical pain, I'm going to expect that. Disease, some limitations, some diminishment of my functioning, my physical functioning. I can handle all that. I just want to make sure that my mind is okay." Have you ever heard that?
Yeah. Oh, yeah.
I've heard that what people fear as they get older is two things. One is being kept alive on a machine, and the other one is memory loss or dementia. Acute memory loss or dementia. And I understand that, but it also says how much we value our cognitive functioning. And therefore how much we fear for ourselves and our loved ones when that cognitive functioning begins to fail. And I think Deanna and Jackie are going to help us understand today how common memory loss is for human beings. And maybe, I don't know if you'll get there, like what the percentage of people is that will experience some kind of cognitive decline. But I think, and I fear, that it's pretty high, especially the older we get.
Yep.
So, for all those reasons, this is a very important topic, and I'm so glad that you're here. Let me introduce you to our two presenters today, who were arranged for us today, by the way, by Carol Jansen, who is not able to be here today, but I thank Carol in her absence for bringing Jackie and Deena to us today. Jackie Abramson is waving her hand at you.
Good morning.
Jackie received her master's degree from Columbia College, Chicago in dance movement therapy and counseling. She's a licensed clinical professional counselor as well as a board-certified dance movement therapist. She's worked at Weinberg Community for the last 6 years, transitioning from creative arts therapist, adult day service coordinator, and is now the Friend Center manager. To her left is Deena Karno. Deena Karno has spent 21 years as a CJE. CJE means?
Council for Jewish Elderly.
Council for Jewish Elderly SeniorLife employee. For the past 5 years, Deena has been the manager of regulatory training and staff development for the CJE system. Recently, she's transitioned to the role of personal care manager and social worker for Weinberg Community for Senior Living in Deerfield. Deena received her Master's of Public Health with an emphasis on health education from Benedictine University in Lisle, Illinois, and her Master's of Social Work from the University of Illinois, Jane Addams College of Social Work in Chicago. Deena is a licensed clinical social worker in the state of Illinois, and very recently, Deena became a certified dementia practitioner through the National Council of Certified Dementia Practitioners. She's an adjunct faculty member in the Department of Health Sciences at William Rainey Harper College in Palatine. Welcome, Deena and Jackie.
We have a quiz. It's got quite a few questions on it. And so we just want to take a few minutes. It says Alzheimer's disease knowledge scale.
Knowledge scale. That's
on the top. And we're going to take about 5 minutes to have you read through those questions and circle the answers. And we're not going to talk about this right away. We're going to come back to it a little bit later in our presentation. So let's take about 5 minutes to do that. Okay. Well, as I said, we're not going to give you the answers to the questionnaire yet. I am the social work and manager of personal care, and what that exactly means is we are in a building that has two sides to it. One side is assisted living, where people have their own apartments, and we have what we call personal care workers that push into the apartments to do things like helping with bathing and dressing and help with hygiene or whatever that person needs. And we have quite a few individuals that have dementia on that side. However, their dementia is not as progressed as the individuals who live in our memory care unit, which is called Friend Center. And those are individuals who really need a lot of supervision during the day.
Anyone ever heard of a dance movement therapist before? You have, okay. Usually people are like, what is that? So it's a master's program where it's a combination of counseling and movement therapy. So you get both your counseling degree and your dance movement therapy at the same time. So have you guys heard of maybe art therapists, maybe more, or music therapists? So it's the same. It's just a different modality to sort of, I can use movement and body language in the counseling sessions to help connect. So definitely people with memory loss and their verbal skills start to kind of diminish. It's a great way to connect with them through body language and through movement. So just a little background on that. Okay, so what are we going to discuss today? So we're going to kind of go over dementia, what it is, and some tips. We're also going to talk about the subjective experience, what it's like for the people who actually have this diagnosis. We're going to review some communication and behavior and what it is to be a caregiver. So we're going to go over some self-care and what burnout can look like. But first, we're going to do just a quick little check-in, okay? So it's 2 parts. I just kind of want to go around the room, tell me your name, and then if you feel comfortable, like why you're here today. If you feel comfortable, is this, you're here because you work with people with dementia, it's a family member, just so we can kind of understand the baseline of the room. And then also I'm going to ask you to show me how you're feeling right now. So I'll go first, and we're all going to try it on. So you guys know I'm here because I'm the manager of Friend Center, which is the memory care unit. And then today, how am I feeling? Let's see. I'm excited to be here, but I'm in my 8.5 month of pregnancy. Thank you, because I think you guys originally scheduled it for February, which was my due date, and I thought, maybe not a good idea. So I'm excited to be here, but definitely there's anxiety in the body as I'm getting closer. So I would say my feeling's excited, but my body has a little anxiety. So I'm going to ask you guys to try that excited with me. I know it seems weird, but on the count of 3, we're going to do it together, and we'll say excited. Ready? 1, 2, 3. Excited. Okay? And you'll see why we're going to do this as we go around. So I'll have Deena go next.
All right. Well, actually, sorry.
No,
my feeling being here today is very excited as well. So
Okay.
sorry to be so generic, but I'll say excited.
So on the count of 3, we're gonna do that. Ready? 1, 2, 3.
Excited.
If you wouldn't mind, or just why you're here today, and then how you're feeling. We're just
I'm
gonna
the
put-
pastor, so I have to be here. No,
Listen, honesty is, true.
no. I'm really very happy to be here, but anytime I lead a public, not lead, but have responsibility for a session like this, I'm always kind of anxious about the details.
Sure.
And will the lunch arrive, and where are the people, and where's the presenter? Not today.
Yeah.
So I'm always just a little bit anxious.
So what does anxious kind of look like in your body, if you had to give a
I
gesture?
don't know if you want to see it, but
Okay, I like that, and we'll do the noise with it too. Okay? So 1, 2. So really quickly, because I don't want to take too much time on this, any idea why, this is a dance movement therapy technique you can use with any population. Why do you think this actually works really well with people with dementia? Why do you think I would use this technique when working with someone with memory loss? Like checking how they feel through movement.
When words can't come.
Very good, when words can't come. Also, it's kind of interesting too, if someone tells me they're feeling really happy, but or it doesn't match with really what I'm seeing, it's a good kind of indicator to see if mind is really connecting with body. So it's just a good technique I give to you to use with anybody you feel like.
Now we're gonna test you,
Yeah.
and you have to do every single
Yeah.
one person's in the room.
In order to get lunch, right. Okay, next slide. Boy. I can still bend. So, Deena did a little explanation. I think the building we work at has a lot of names. So the whole campus is assisted living. It's called Weinberg Community. It's got 2 parts, okay? On the left is the Gidwitz part, which is the assisted living. It's all assisted living, but standard assisted living, which has 125 1- and 2-bedroom apartments. And so it's for seniors who desire socialization and supportive resources. So you can still get activities and get med reminders, but it's not a nursing home. So it goes independent living, assisted living, nursing home, we're in the middle. Does that make sense? Okay. And then what's nice is that the community is connected through a hallway to the Friend Center, which is where I work, which is the memory care. So it's a 40-bedroom apartment unit for people with stages of Alzheimer's or other related memory issues, and that is a secured unit because people do tend to wander. Both sides have a courtyard, but on the right side, that's a picture, I don't know if you can really tell, but it's a gated courtyard, so people can still walk and not elope.
And where? I'm sorry.
On the right side, the Friend Center.
No, where's the Weinberg community?
Oh, Deerfield.
Oh, dear.
Yeah, I didn't mention that actually. We're in Deerfield. But what's nice is that the buildings are connected. So like, let's say, Gidwitz has a lecture or a music performance. We go back and forth. There's a lot more opportunity for resources and continuum of care when the buildings are connected. So we just have a little clip at the bottom. I kind of just want to show you so you can sort of get a feel. Because I think when people hear assisted living, everybody kind of has their own bias. So I kind of wanted to give you just a little bit of a video of what it looks like.
We are all present here, are all part of the Gidwitz Ambassador Program to welcome new residents into a community that we hope they will enjoy.
It's an interesting program, and you, based on your own background, you can make use of your own experiences and knowledge to make people acquainted with the facility and make them feel at home.
We match up a resident that's living there with a new resident, and they go in, they invite them to come to a meal and introduce them to other residents.
I guess moving in any place is not easy.
It can be very, lonely to just be thrust into this without some kind of steps.
The receptions that we have is really what's been nice is they're all getting together and it's kind of forming a community on their floor. And we did have kids from middle school who came in and they actually knocked on the door and invited residents to come. I think it's really hard to say no to a young person.
They're all so welcoming and homey, and so it's really nice to be here and you feel like you belong even if I'm 50 years younger than some of them. It was nice to see that there's such friendship, and it was just, I think they were really happy, so that's cool.
It's a good community. They make it pretty good for us here.
objections? Yeah,
Just a question.
Sure.
Do you have to be Jewish?
no. Mm-mm. I mean, obviously, there are religious programming, geared towards the Jewish community, but no, that's not a requirement. And I mean, if you want to go to the next slide, I can even explain. Inside of the Friend Center, which is the memory care, we have what's called Adult Day Service, which is open to the public. So that's an opportunity for anybody still living at home to just come for classes who has memory loss, and I would say that's how we get a lot of people who are also not Jewish. We have a relationship with the VA, so I get a lot of veterans sent to the day program. And so this Adult Day Service within the Friend Center is geared towards people in different stages of Alzheimer's disease who need extra support and supervision. And it's also an opportunity for the caregivers to get respite, right? Because then they're at a class and the caregivers can go to the grocery store or go get a manicure, or it's a great opportunity for people to get a break. I think what people don't realize too is, and I kind of wanted to pass a couple of these around if you wouldn't mind, or do you want to pass? Well, I just quickly. Thank you. So this is the activity schedule at the Friend Center Adult Day. Yeah, take one and pass them around. So the reason I think that this is important to see is we've got classes from 9 a.m. to 9 p.m. every hour, multiple classes going on at a time. So it's just constant music, movement, art. Every Thursday we go out somewhere for lunch. We've got live performances, volunteers, dog therapy. So our philosophy at Weinberg Community is we're very activity-based, strength-based. We're trying to get people involved as much as we can. So I just think if you're looking for creative things to do with the people you're caring for, this is a great resource for you to look at some classes. Okay?
I see yesterday
Yeah.
was Squirrel Appreciation Day.
Yeah.
And I would just like to know why my dog was not invited.
Right, exactly. Yeah, exactly.
National Blonde Brownie Day.
Oh, yes, see? Yeah.
I'll just mention also, we have, so we're part of a bigger agency in the Chicago area called CJE SeniorLife, as you saw. And we have all kinds of services for older adults, not just our assisted living facility. We've also got a nursing home, which is in Skokie, called Lieberman Center. But we've got all kinds of other services for people that are still living in their home in the community. So we have a counseling program where we have licensed clinical social workers that can go to somebody's home, or they can come into the center and get counseling. We have Meals on Wheels. We have a transportation program. And we actually have a second adult day service program, which is
Closer
in
to here.
Evanston. Yeah,
Yeah.
that's why I mention it, because if that's something that maybe interests you, we also have another center which is on Howard Street in Evanston. And we've got all kinds of other services as well. We have some literature over there, and there's really one main number you call to get information about any of the services that we have, and it should be on the literature over there. So anyway.
No, yeah.
you go
I mean,
ahead.
that's perfect because it goes into the next slide, I think, of other resources that are specific to Weinberg. But again, of course, we can give you resources that are closer to this area, absolutely. We started this thing called the Eden Project, which is a volunteer opportunity at Highland Park Hospital and Glenbrook Hospital. Anytime someone from our community gets sent to the hospital, I mean, it can be very disorienting, and sometimes family members can't be there. And so we train the volunteers at the hospital to how to work with people with dementia. So if you're ever interested in sort of getting involved in that, I'd be happy to give you the information. Yes.
Many
You've seen it.
experiences.
Yeah, the hospital's not fun.
And remember, like, they fall all the time.
Yep.
And then they have protocol. They don't even wait to call you. They just whisk them off to the hospital, and then
Yep.
they can't restrain people anymore. And so, it's such a mess.
Exactly, and they just don't have the time to sit and make them feel comfortable, and so having someone even just be in the room and playing music, holding their hand, we've seen such positive outcomes from this project. So if you're ever interested in another opportunity, let me know. Also, Deena and I do a couple of support groups. Do you want to talk about yours real quick?
Sure. So I do a support group. It's based at Weinberg. It is the first Tuesday of the month, at Weinberg, and it's the caregiver for those with dementia support group. And so anybody that is a caregiver for someone with dementia, any loved one, it's a place to come and talk about how you're feeling, share information on different resources, all of the above. So that's something that I do once a month.
And I do the Parkinson's support group. It's for the caregiver, so it's a two-parter. So every Wednesday and Friday, the person who's diagnosed with Parkinson's, we have a free exercise class every Wednesday and Friday at noon. And then on the third Wednesday of the month, I facilitate a support group for the caregiver, for the person who has Parkinson's. So the flyers are over there, but we just wanted to give you all the resources that we could think of. And then also Memory Cafe. This is a brand new program we started, and memory cafes are everywhere. They're popping up everywhere. So if ours is too far for you or for the person you're taking care of, we'd be happy to help you find one in the area. But ours is the second Thursday of the month, and every 4 o'clock. And every month it's a different topic. Like last month we had music therapy, and then we'll have a lecture, and then we'll have art therapy, and then we'll have a lecture, and it's free, and there's food, and it's just an opportunity for more resources. Sound good?
Is the Memory Cafe for caregivers or?
It's for both. It's really intended for the caregiver and the person with the diagnosis to come together. It's not a drop-off like the day program. It's for you guys to be together. That was a good question. Thank you.
All right, so we're going to move on to really talking about dementia now, and we're going to pass out the answers to the quiz. All right, so which questions did you struggle with? Are there any that you have a particular question on that you don't understand or that doesn't make sense?
The first one, I happen to become acquainted, my sister's former husband's mother.
Okay.
We used to call it forgetfulness or something. She'd wander. And you'd ask her a question or ask for an answer, she'd answer, and then she'd ask it right back again. She had no short-term memory left. And we realized eventually because it was Alzheimer's. But the top one, people with Alzheimer's, particularly prone to depression, she was a happy lady. And that was my first reaction when I looked at that, remembering her.
Sure.
So I think it's all kinds.
Yes, absolutely. So in general, oftentimes you do find that people with memory loss, Alzheimer's will have depression, but it, of course, by no means applies to everybody. Absolutely. Everybody's different how they experience Alzheimer's disease. Yeah. Anything else that you have a question?
That was one thing about depression too, I realized in my husband.
Yeah.
With all the things that are going on, I'm amazed the fact that he didn't get, or has not at this point gotten depressed. Because I would have, I was depressed of all the things that were going on. He comprehended his diagnosis and the stuff that's been going on with work and all that stuff. And he still gets up every morning and, I'm not saying he's over the moon happy, but he's getting up and moving and productive, so, yeah.
That's great. That's great. And go ahead.
You can finish what you were going to say.
I was just going to say, this one is an important question because sometimes people that look as if they have memory loss may have the beginnings of depression, and you treat the depression and you see them go back to their baseline and they don't necessarily have memory loss. We call it pseudo dementia. And so it's very, very important that, of course, anytime we think somebody may be showing signs of dementia, that they have a full workup by a physician, and sometimes even sending them to a psychiatrist to determine if they have depression, because it may be that all they need is therapy and some medication, and that may reverse some of those things that we're seeing. So yeah, that's a very important question when it comes to talking about dementia.
That's really important. I did not know that there was an average life expectancy. And I've heard of cases like your mom, where very healthy body, and so people go on. Do you know how much that differs from the life expectancy? Because normally Alzheimer's occurs in people who are older. how different is that life expectancy from average people who don't have it, would be a question I have.
I don't know if I can answer that question directly, except to say that people with Alzheimer's, as they progress in the dementia, are very prone to lots of different things that can affect their life expectancy.
Sure.
So
Right.
the falls.
They can have accidents or falls.
The falls, yeah.
Right.
Or not be able to care for themselves or communicate once.
Well, being susceptible to infections like pneumonia. Sometimes what we see is as someone declines, they don't have an appetite, and we don't know why that is. If it's just that part of the brain is not working anymore, but we see them not eat anymore, and so.
But doesn't that occur with aging anyway? Sometimes, I mean.
It can, but But it's not as common, I think, in a person without a diagnosis of dementia versus somebody with a diagnosis of dementia.
I have friends, both died of dementia, and I've been in touch with their daughter. And I said to her, because they both just rather quickly seemed to me. I mean, they were confined, but they went quickly. And she said, well, the brain just stops functioning.
We're going to talk about
We'll talk about
We're
that.
going to talk about that, yeah. Absolutely. Any other questions?
I think the other thing is too, is when that person is actually diagnosed, because this could all been happening months, years beforehand, and until you get that official
That's a great
diagnosis,
point.
that doesn't mean that's when the clock started. It could have started years before.
Yeah.
And I just think this brings a good point too. When I meet a family for an evaluation, one of the questions they always ask me is like, well, how much longer, are they gonna have? I mean, 6 to 12 years, it's kind of a range.
Right.
And so I just think the point of this is it could be a couple years, it could be the 12 years I could know somebody. So it's just to keep an open mind that there's not like a set, no one's gonna be able to say to you, you got 5 years left.
Well, and also too, I found frustrating, just because I'm a planner, I was like,
Right.
okay, well, what does next year look like?
Right,
What
we
does
can't
3
tell you
years
that.
like? It was like, I don't know, like.
Right, I think that's the point of this, is I can't tell you. What I usually say is that people don't necessarily pass away from dementia. It's what she was saying, and something else is gonna happen to the body or to the brain that will, yes.
To what extent has research shown that Alzheimer's is characteristic of families? To what extent if one person has Alzheimer's?
So they have found that there are certain genes that few people carry, that it's, if that gene is passed on, that person is pretty sure to have Alzheimer's disease. The biggest risk factor for Alzheimer's disease is age. So for the whole population, as we get older, so into the 80s, 90s, everybody's chance for developing Alzheimer's disease increases. So they haven't necessarily, most of the cases of Alzheimer's, they have not found to be genetically linked. But there's a lot we don't know about what happens with Alzheimer's. There's a lot we don't know.
The reason for asking, some of us remember Clara Beth Kerner, who years ago would read the Passion story on Holy Week Sunday, Palm Sunday. And I was the one who was acquainted with her. We'd hike together when she was still living in Northbrook, a few blocks from me. And then she moved to Axelson angrily. And boy, was she hard on her daughter. And I visited her there, and there were some very difficult days.
Sure.
Is that characteristic of Alzheimer's?
You know,
She resented giving up her apartment.
Oh, yeah.
Yeah.
Well, nobody wants to do that, whether you have memory
But
loss
she
or,
was vitriolic about
Sure.
her daughter who was doing
Loss
her
of
best,
independence.
Coming in from California to help her. It was
Sure.
really tragic.
yeah,
Sure.
and there's a lot of emotion tied
Oh, and
to
her two brothers had Alzheimer's.
sure.
Wow. That's the velvet.
So yes, there's a lot we don't know about it, and maybe in the future they will find that there is some kind of familial connection, but right now, generally, most of the cases of people that are diagnosed with Alzheimer's, they don't feel that there's any kind of genetic connection.
You keep saying Alzheimer's, are you equating it with all dementia?
So we're gonna
let's
move
go
on
to
to the next
slide.
Yeah, let's move on to the next slide. Very good question.
Good segue.
You cannot diagnose Alzheimer's until autopsy.
Correct.
So yes, so whenever I start a conversation about dementia, I always like to talk about just what you brought up. That dementia is really a label for a set of brain symptoms. And I equate it to, let's say you go to the doctor, you have a cough, you have a sneeze, a fever. When you get to the doctor, they're not going to diagnose you with cough, sneeze, right? There's either a virus or there's a bacteria that's inside you that is causing these symptoms, right? So I equate that to the same thing to dementia, that dementia is a label for a set of brain symptoms, which we're going to look at those symptoms in a couple of minutes. And there is some underlying disease that has an actual name that each disease in its own way has a way of destroying brain cells that cause these dementia symptoms. Does that make sense? And we're going to take a look in just a minute of a slide that talks about some of the more common diseases that destroy brain cells and cause dementia symptoms. So I always like to start my conversation with that. I always like to point out that unfortunately these diseases that cause dementia symptoms, all of them are progressive. So as time goes on, that person is not going to recover, unfortunately, and disabling usually to the point that interferes with daily functioning, unfortunately. Yeah,
When you say it's progressive, I've noticed great days, terrible days.
Yep.
Do those just get smaller, like it just becomes terrible days, or is it always great days, terrible days?
You know,
Well, what I always say, that people ask me that all the time, is if you've met one person who has dementia, you've only met one person. There is no case is the same, every case is different. And it's gonna go up, it's gonna go down, some days are great, some days they'll recognize you, some days they don't, it goes back and forth. There's no one trajectory, it's different for every single person, which makes it even harder. Yes, yes. That's why this is the hardest part, to hear that it's progressive, there's no cure. Yeah, it's that spiraling that we did at the beginning, absolutely.
But you know what, I think part of what I had to learn is, yes, we had good days, we had bad days.
Sure.
But I think I was judging them, and I think part of it was for me to learn, okay, I may think this is a bad day, maybe I have to step back and say, and so what we try to do is, it's a lot more managing on my part, but try to figure out what those things are that can make his day better. And
great point.
And try to avoid those triggers. It's very hard right now because there's many things that I can't control. But some of those things, you know, so if he wants to watch Andy and Mayberry for
all day, fine.
You know?
Exactly.
You know, we go, that's what we do, but it is very frustrating for the person who, well, I think it's frustrating for both parties, but
for sure,
trying to establish what that new norm is.
So sort of redefining.
Great point.
What your expectations are, yeah. And, you know, in the course of dementia, it can be different in different sort of periods of time. So, you know, you may have somebody that starts getting agitated on a daily basis. And unfortunately, as when we work with people, that sometimes we'll say, well, at some point they're probably going to decline. And people are almost thankful for that decline because maybe the agitation goes away as a result of it. So you know, it's just so hard to define. It's really hard to define.
It's all about outlook, honestly,
yeah.
with each phase.
So these are some of the common diseases that cause dementia. And of course, the one that's at the way top is Alzheimer's disease, because Alzheimer's disease is the one that is really the culprit for about 50 to 75% of cases of dementia that we see. I don't want to spend a lot of time talking about and breaking these up because we don't have time, and I think our time is better spent on talking about other things. But just to run down, I'll just say a few things about each one. Vascular dementia, that is where someone has either had a major stroke or maybe a series of mini strokes, and now the brain is becoming affected by those strokes. Parkinson's disease, that's more associated with movement problems. It's a movement disorder. But sometimes when someone gets a diagnosis of Parkinson's disease, they will get very scared, understandably so, that for sure they're going to be diagnosed down the road with dementia. And I always like to say that only about 50 to 60% of people diagnosed with Parkinson's will end up with some kind of Parkinson's related dementia. So it's not by any means everybody that's diagnosed with Parkinson's. There's something called Lewy body dementia, and they know that this is related somehow to Parkinson's disease. When they upon death and they look in the brain, they see structures in the brain that they also see in people with Parkinson's disease. And so they know, because they see these abnormal structures that are killing brain cells, that they are related. So you may see some overlapping of symptoms with Parkinson's and Lewy body. And Jackie, I know you can give maybe a description of...
It's, the way I see it, it's like a combination of Parkinson's and dementia. So there's a lot of body side effects and the brain. It's quite a combination of both. It's a tough one.
Mm-hmm. And then the last two, you may have heard something called FTD, frontotemporal dementia. It's called frontotemporal dementia because it's the frontal lobes of the brain. If you cut your brain in half, they're symmetrical, and you've got two frontal lobes, two temporal lobes, and then other lobes as well. But it's the frontal lobes here and the temporal on the side that are affected. And they're quite different in terms of the presentation in the beginning when someone's diagnosed. You don't see a lot of memory loss, you see a lot of behavior issues. And for some, so frontotemporal dementia and primary progressive aphasia, these are both frontotemporal diseases. So with frontotemporal dementia, you see more behavior issues with that person. So things like socially inappropriate types of behavior. So maybe using their hands to eat at the table,
vandalizing,
compulsive gambling,
sexually acting out.
Sexually inappropriate behaviors in public, those kinds of things. Mm-hmm. Whereas primary progressive aphasia, again, you're not going to see short-term memory in the beginning. We're seeing more language problems. So having trouble with word finding, eventually losing the ability to say words at all. They still may be able to maintain the ability to write. So you may see somebody that carries around a notebook so that they can communicate by writing. And eventually, all of these, as people really progress into the later stages, they all start to look exactly the same. You don't know the difference between either one. It's really the presentations in the beginning that help doctors to figure out what is going on and which one of these diseases that person has. Doctors have gotten very good at diagnosing based on the beginning presentations of them.
This might be way too specific, but it was recommended that we get an MRI, even though we've already had this evaluation, and she's like, it'll only corroborate what I say, it's not gonna be anything. So I'm like, I don't know how important it is to put someone through that to get to one of these, or...
If you really are stuck on knowing and having an answer, it could be, to be honest, the way you respond to and work with people with any of these dementias is very similar.
Same with medications generally. I'm not a doctor, but I think maybe out of the list, Parkinson's maybe, if you were thinking that, because there's specific medications for that disease. But the rest, it's, keeping comfortable and quality of life. I don't think it really...
And the approaches that you're taking
Yeah.
are just going to really overlap and be very much the same. The bottom two are a little bit different, like I said, because
Sure.
what is going on with that person is very different than memory loss. But eventually, as the disease progresses, they lose memory long-term and short-term as well. So these are the symptoms that we see of people with dementia. We kind of simplified it on this slide. So problems with short-term and eventually long-term memory. Which one do you think goes first?
Short term.
Yeah, so I hear pretty much everybody agreeing that it's short term. So if your brain, every part of your brain is responsible for a different function in your body. And I say that because people will always say, well, why is it always the short-term memory to go first? With really any of these diseases that cause dementia, why does short-term always go first? You'd think, I always think of it as, you know, your memories are a big bag. And as you have them, you're throwing, you know, the memories on top, and so the long-term ones are at the bottom of the bag, so why wouldn't those go first versus the ones that are close to the top? Why wouldn't you remember those? Well, the answer for it is there is a part of your brain that is responsible for housing short-term memory, and with all those diseases, for some reason, it is usually the first to be affected, and that is why we see problems with almost all those diseases with short-term memory first. And then as it progresses through the brain, it eventually goes to the area of the brain that houses long-term memory, and then we see problems with long-term memory. Difficulty planning or solving problems, performing tasks. So I know brushing your teeth doesn't seem like, when I say problem, I'm not using problem and we have a problem to solve. I'm talking about problems, tasks that have a series of steps. So when you brush your teeth, you're probably thinking about 100 other things when you're brushing your teeth. And we've got what's called muscle memory. Your hand is doing what it needs to do to brush your teeth. You know, you're taking out your toothbrush, getting some water on it, putting the toothpaste on, brushing all the surfaces, washing off the toothbrush and putting it back where it belongs. You're not thinking about every step as you go along, right? It just kind of happens. Your arm just does what it does as you're thinking of a million other things. The person with memory loss and that has trouble remembering those steps, they can't think logically through those steps anymore that they're supposed to take. And so some of it is the fact that they have memory loss, and some of it is the fact that the part of the brain that allows us to plan things like planning a vacation or planning how we're going to financially maybe, you know, plan a party or something like that, that part of the brain that allows us to logically think through those types of things eventually becomes affected as well. Confusion with time or place, and people as well. So I think anyone who knows somebody with dementia is very familiar with that you could ask somebody who has, you know, maybe even mid-stage, what year is it? And they may be back in the 60s, thinking it's in the 60s. You may ask somebody where they are, and they might have no idea of the place that they're sitting right now and may give you an answer from a memory that of somewhere they were in their past. Impaired judgment, so not making very good decisions. Has anyone ever seen, and this speaks to it, has anyone ever seen somebody in the summer who has dementia put a winter coat on and go outside? Okay. Has anyone seen somebody in the winter put shorts or very little clothing on and go outside in the winter? So that kind of speaks to judgment. They don't have that, again, that logic, that judgment to think through, it's cold outside, I need, you know, to cover myself to make sure that I stay warm. They don't have those associations, they don't have that ability to think through those things anymore. Misplacing, losing things is of course very common. Sometimes, as Jackie and I were preparing for this, we were talking about this, that sometimes people will think to themselves, oh my God, I lose my keys all the time, I must have Alzheimer's disease. We really say that people misplace things all the time, and that's not necessarily indicative of Alzheimer's disease. When you start to find the keys in the refrigerator, or when you start to find them in odd places that they don't belong, that's a little bit more alarming. Right. Problems with speaking and writing, eventually somebody's area of the brain or areas of the brain that are instrumental in language, whether that's reading, whether that's speaking, whether that's writing, those eventually become affected as well. And then we see withdrawal from work or social activities, and I like to speak to this on two fronts. So sometimes in the beginning, of course, because that person is very embarrassed and they're very aware of the fact that they are having problems, and so they may start to withdraw from groups, activities, places that they used to go. And then later in the disease, as people really progress in those later stages, we see people kind of withdraw, don't make a lot of eye contact with others around them, don't have the ability to start conversation with people around them as well. So before we move on, are there any questions about the symptoms?
I think you guys kind of spoke to the mood and personality changes. A lot of times when a family member comes to me, they'll say to me like, my mother never cursed in her entire life, and now that's what she does. There's some, or the other way, I never got along with my loved one and now we're best friends. So there, I think people think there's like a, maybe like a judgment that you think people with this diagnosis are gonna be aggressive or acting out, which is a possibility, but there's also the possibility of it completely switching the personality into this loving and caring person. It really can go either way.
So let me just address, you were both talking about music and how music has been either a way to connect or something that's been very important to that person with dementia. So we were talking about the brain and the different areas of the brain that are responsible for different functions. So what they found is that the area of the brain where music is important to us, or if that, because some people like music, some people don't like music, and that's, it has to do with your brain, some of that the area of the brain that's responsible for either enjoying music, having connection to music, that is preserved well into the later stages. And so that's why we see people being able to either enjoy it or, somebody can't tell you what they had for breakfast, or they can't even remember maybe their very many memories from their wedding, but you put something that's really familiar to them on in terms of music and they can sing all the words.
Yeah.
So it's that part of the brain that's preserved. Yeah, which is great, because if that's something that they enjoy, then that's something that's a good tool. That's something that you really use to connect with them or give them enjoyment in the moments, since that's something that is meaningful to them.
That's why those creative arts, the dance, the music, the art, that's why it's very important. I think if you can push those activities as much as you can. Yeah.
Before you were talking about the phenomenon of pseudo dementia, if that's the case, and if depression over the losses of aging, not being able to drive, et cetera, are having a more restricted lifestyle, how would that look different, or is that too detailed a question? Would there be some of the same symptoms?
So when you think about people with depression and some of the symptoms that they present with, you may have somebody that really kind of withdraws, someone who is very hard to engage. You ask them a question and they say, I don't know, which someone with dementia, you ask them a question and they'll, because they don't know, right, because of their memory. So some of those symptoms may look parallel, and you think, oh no, this person has memory loss, when it's really that person is just so depressed, they don't have the motivation to answer the questions or the energy to do those things. And so that's why it needs to be teased out. Yeah. And that person can be given medication or therapy. Mm-hmm. So we like to talk about the subjective experience of Alzheimer's disease and the other diseases that cause dementia, or just feeling dementia, to try to give people just an inkling of what it might feel like in some of those moments for people with Alzheimer's disease. So I want you to think about, did you ever wake up for a moment, felt really disoriented, like you had a dream maybe and you couldn't, for a few moments when you woke up, was that dream reality? Did that really happen? Or did that not happen? And think about, especially if it was a dream that was frightening, that sort of anxiety-producing feeling. And that might help you to understand what someone with dementia is feeling in some of those anxious moments. Or ever reach into your purse or your pocket, I mean, I'm sure we've all done this before, and find that our wallet is gone, and that just sort of anxiousness that, you know, something familiar to us that we really rely on and need is not there anymore. Or this one happens to me from time to time. I'm driving, I'm really deep in thought. And you know how people talk about, how did I get from here to my destination? I wasn't even aware that I was driving the whole time. I was thinking of so many other things. But it's happened to me once in a while where I've been deep in thought, I'm driving, and all of a sudden I realize I'm still driving and I think, where am I going? Like that kind of terrifying feeling like, oh God, I don't know where here I am in this car, and I'm supposed to be going somewhere and in control of this car, and I don't know where I'm going. So if you've ever had any of those experiences, that might give you sort of a hint of what it feels like.
Always? I mean, is this a state of mind then, of anxiousness always?
Not always, not always. But people, and I'll let you answer this too, but people that work, for instance, in memory care, it's upon them to know how to try to bring people out of that state, either with activity, with redirecting them, with distracting them. You can say a little bit more about that.
Yeah, no, and I think, I think for I'm sorry, I'm not bad at that. The purpose of this is so you guys can, when you're working with people who are in this, is trying to relate to them on that level, and like she said, try and bring them out. I think that's the goal.
Cues were the words we're using. You need
Sure. Cues, prompting,
move
cues.
to somewhere else.
Correct. We want to, like, the thing is that this is their reality. This is how they're going to feel. It's not our reality now. They have a whole new perspective of life, and we can't change that. It's how we can be with them in that reality, how we can keep them comfortable if they are in this anxious place, how to pull them out of, and we're going to go over tips with that too. Yeah.
And although we can't reverse these diseases that cause dementia, there's a lot that we can do to treat these particular symptoms that we're talking about. So I don't want to scare people and make them think, oh my God, if someone has dementia, they're just in this horrible anxious state all the time. Yeah. No, it's not always like that. I mean, you may have somebody who is in a bad period, and that's where a lot of times we'll bring in a psychiatrist to prescribe something to make them feel better so that they don't feel like that. But I by no means want to tell you that this is how somebody feels 24 hours a day, 7 days a week, all the time, on and on and on, yeah.
Do the folks with dementia, do they just take these, the feelings on that this is their day-to-day? Do they, and maybe we can't answer this, do they know this is going on? Because that was the one thing with my husband over the last couple of years. It was always like, don't you see these issues? Don't you? And he's like, you're crazy.
Yeah.
I'm perfectly fine. And I don't know how much of that was denial, just because maybe he did sense
probably
these
both.
things, or, he has no idea.
You're right, it's hard.
What we're seeing.
It's hard to
tell.
separate. Yeah. It's hard to separate. Because if your reality, the person with dementia, their reality to them is just as real as your reality to you. Yeah. And so it depends on what his brain is telling him is reality.
And it's really harder for you guys than it is for them, I think. That's what I tell the families all the time.
So too.
Like in their reality, that every day they're just, things are going and the flow just keeps going, but you, as the caregiver, has to watch all the changes. I don't think they're necessarily grasping all. And I think this clip we're going to watch is a good example too. Yeah.
But I think some people, the person that I'm thinking of does know that she's losing her memory.
Early
and
onset.
Very upset about
it's
it.
almost
So
like I
maybe
say.
That depends. Mm-hmm.
Yeah, absolutely. I didn't mean to cut you off there, but absolutely. When I meet someone at the early stages, it's almost like the families can get a breath once they've sort of progressed into other stages where now they can't tell that they're losing stuff. Mm-hmm. It's almost like then, it sounds strange, but when they progress, you can kind of breathe because that recognition that they're losing stuff is really hard.
You get the diagnosis.
Oh yeah, that part is really hard.
And actually to respond to your, do you get an MRI or not that I'm suggesting either way, but when he was in the hospital, he did get an MRI.
Okay.
And so it was this detailed map for us to see all the other things that were going on in his brain. And he has cerebral amyloid angiopathy, which and we saw several brain bleeds, and we saw several mini strokes that we wouldn't have known. Not that that changed the dementia diagnosis, but you're like, there's a lot of other things going on
Sure.
too. So, and maybe that's just because we needed a bigger roadmap. I don't
Sure,
know.
some people love the information. I think it depends on what type of personality you have. Like if you're someone who wants to know, or if that might overwhelm you, I think that you're gonna have to find within yourself.
And some scans can show, you know, what parts of the brain are active and which ones are not active anymore, which gives you information about a little bit about what that person is able to do still and not able to do still.
Good point.
So
yeah. Actually, all brain function, if something else doesn't kill you first, that's what happens? All of your brain function pretty much, do you live long enough?
Yeah, some people will live until the part of the brain that is in control of breathing and heartbeat, until that shuts down.
Okay.
I think that's more rare case
That's
though. I
rare.
think people tend to die more from either an infection or from stopping eating. And that,
Or fall.
Heart disease.
A couple falls.
or yes, other diseases that
That's
are
right.
going on at the
Yeah,
same time.
sure.
But if you go in basically healthy, other than memory loss.
And there are a lot of people, like families will comment when you look at somebody's medications that they're taking, they're hardly taking any medications. It's the memory, it's the.
Physically fit.
It's
But
the
the brain
dementia,
starts to shut
yeah.
down. I think this clip, and I think it'll bring you guys into this space too. It's from that movie and the book Still Alice. Have you seen it? This is a clip of the daughter asking the mother, so she's earlier onset, how she feels. And I think the way she describes it is pretty interesting. So.
What's it like? Like, what does it actually feel like?
Well, it's not always the same. You know, I have good days, bad days, and on my good days, I can, you know, almost pass for a normal person. But on my bad days, I feel like I can't find myself. I've always been so defined by my intellect, my language, my articulation, and now sometimes I can see the words hanging in front of me and I can't reach them and I don't know who I am and I don't know what I'm going to lose next.
Sounds horrible.
Thanks for asking.
Reactions?
It reminds me of a similar conversation I had when my mom was at that stage.
Yeah.
And she would, and tell her that, because she would deny a lot, you know, you'd say something like, you know, this person died, and she'd be like, no, that didn't happen. Like,
right.
Okay, I would look at her in the eyes and say, you need to know that as you're losing your memory, you're not gonna remember things, and you need, like, the people that you know and trust until you stop knowing who those people are. I will always tell you the truth. And it's not always gonna be easy, but at least you know, I'm gonna look at you and I'm gonna tell you the truth about what happened. And I said that to her for like a couple of years right in the beginning, because I thought, oh, maybe that would stick, because they get to a certain point where, you know, they believe white is black and black is white, and, you know, most of the time it's like, okay, sure, yeah, it's zebra, whatever, it doesn't matter. But then sometimes it gets to a point where things really do matter, and they really do have to know, and so you need them to be able to trust somebody. I mean, that only lasts in the beginning, you know, it's only a good tool in the beginning, but at least, I think if that was happening to me, and someone said that to me, like, you know you can always trust me, and I will tell you the truth, that would be helpful to me.
We're going to teach you another technique too, And you guys get to pick. We're gonna give you as many resources as you can, and I totally hear you, but there does become a point, and I don't know if I'm skipping to it too early,
No, that's all right.
where we call it a therapeutic fib, which we're gonna also help, which I think is a great technique for you guys to learn. So we're gonna come up to that too. Because, I mean, honestly, there's not one right answer. You're gonna wanna have as many tips as you can, or techniques.
We're going to skip this one right now, just because we're seeing that we want to make sure we get to the most important information for you. So these are obstacles to communicating, and you have this slide in your packet, so we'll let you take a look at it. You know people with dementia, and so you probably know that these are a lot of the obstacles to communicating. So we're going to move on to the next one. Just want to make sure that we address this, that in addition to having a disease that causes dementia, somebody might have these things going on as well, which might compound the dementia. So, you know, being hard of hearing, having poor eyesight, pain or discomfort, that can really throw things off if somebody's in a period where they're having pain or discomfort. And I'm not sure how.
Language.
Okay.
And eating, if someone's having an
Okay.
eating problem, or if they're having a hard time speaking, like these are some things physically you can address to try and help decrease some of the other symptoms, but these are just good things to look out for. If they can't hear you and they're having memory loss at the same time, it's a very difficult combination to work through.
So I want to talk very quickly about, we're talking about how the subjective feeling, and people with dementia, they may have some periods of feeling anxious, like they're not in a familiar place. So as human beings, I'll just ask you this question: do we desire having control, or letting things to a higher power, or to other people to decide for us? Just what is our nature in general?
Control.
We
I don't
want,
like being told what to do.
it's human nature that we want to have control of as much as we can, anytime we can, as much of the time as we can. And obviously we all know that that is not possible. But think about it in the way of a person with dementia, that as they start to experience these symptoms of dementia, that they are feeling more and more out of control, right? And sometimes, this is why it's good that we teach people how to work with people with dementia. Sometimes caregivers are not giving them the ability to control what they can. And not that they're ill-meaning,
Right.
not that it's not well-meaning. People sometimes just don't know that, you know, I think I'm gonna take care of everything for that person because I don't want them to worry about anything since they have this diagnosis of dementia. And then we go ahead and we do everything, or as much as we can possibly, for them. And what happens when somebody doesn't do things for themselves anymore? They lose it, right? If I don't continue to keep dressing myself and someone just comes every day and dresses me without giving me an opportunity to try myself, I'm gonna lose that skill.
And the motivation sometimes too. If someone's doing everything for you, they're not gonna wanna try and do it on their own.
Right, and the emotional component of, well, everybody approaches me like I can't do anything. I guess I can't do anything anymore. And then they take that on emotionally for themselves. So I think it's really a good point to stress that when we're working with people with dementia, we want to make sure we give them the opportunity to be in control. So, you know, when we talk to staff and we do training for staff at work, let's say you've got somebody who really does have a hard time dressing themselves, but can you take them to the closet and say, what would you like to wear today? And if that's too broad for them, to pull out 2 shirts and say, would you like to wear the purple shirt or would you like to wear the red shirt? Because we're giving them some kind of choice and we're allowing them to choose for themselves. And I might hand the shirt to them and say, okay, go ahead and put the shirt on. And then if they can't do it, if they're not sure how to do it, then I'll step in. But allowing them to do as much as they can for themselves and to have that control. Because if we don't give them control, people with dementia, they still have a sense of, they may not know the content of what you are saying to them, but they know how an interaction feels. They are still able to pick up on how that interaction feels. And if you're treating them like a child, or not, like you're not giving them choice, then they may just push back because it feels bad to them. And so I always like to talk about that. I also like to say that we want to try to steer away from saying the word no. So, you might have somebody that's got dementia who's wandering and rummaging through things, and I come up to Jackie and I say, no, you can't do that, you can't do that. We want to try to steer away from no, and instead of approaching with a no, we want to approach with, oh, look over here, here's something you can touch, here's something, come on over here and let me show you this, instead of saying no. There's a big difference in that interaction and how that person with dementia perceives it.
This could be a parenting slide.
Yeah,
Absolutely.
I last night was at the hospital taking a baby training class. It's like the exact same feeling. Yeah.
But it's for the
Eye
same
contact.
It's for the same reason.
Yeah.
Because
Keeping them
children, as
comfortable.
they develop, they want more and more and more control. That's our nature
Yeah.
as human beings. And so,
What's the word for that with children? Not distraction.
Redirection. Oh yeah,
Redirection.
we use that phrase all the time in our field. Redirect. Yep.
So things like cooking a meal. They might not be able to cook the full meal, right? But you may be able to give them a task like to put the plates out on the table, or to do something else, to stand there and maybe pour something into, the mixing bowl. So involving them like that. Eating a meal. Sometimes, or often, we give a lot of thought to people who are in those stages that have a hard time manipulating the utensils. Do we do more finger food so that they're more successful on their own at feeding themselves? I talked about dressing, showering. Many times people with dementia have a hard time bathing themselves, and so allowing them to maybe pick the soap that they use, giving them a choice with that, and giving them other choices.
I heard recently an interesting tip about showering, if this comes up in any of your lives, because there's a lot of things in the shower, like the soap, the shampoo, the conditioner, and that can be kind of overwhelming to them. So someone told me a great tip: if you buy an all-in-one, like
shampoo, body, and
that can help.
Yeah.
Because there's just too many, the hot water, the cold water, the soap, so that's just a little.
You know what's funny with that? Sorry.
No, yeah, that's.
I'm finding that if it's not what it used to be, like he doesn't understand his phone can go anywhere. A phone stays on the table.
Oh yeah,
so
phones.
That's not happening.
Yeah.
And this thing, he'd be like, "Where's the bar of soap?" It's just like he doesn't recognize that is now the new thing.
Body wash.
Oh yeah. absolutely.
And that's
For sure.
the biggest thing you can learn is laugh at those things.
Oh yeah.
Amongst yourself, even
You
laugh
can laugh.
about.
Yeah.
What we laugh about these days, I never would have thought I would ever be laughing about. Yeah.
Absolutely. Sense of humor is important.
So we want to talk about some general communication techniques. And then we're going to go into talking about 3 different approaches that we've sort of developed over the history of working with, not me personally, but just humankind, working with people with dementia. So just some general communication techniques. Really focused listening. Especially if that person is having a hard time getting across what they're trying to communicate, really focusing on them, making good eye contact, showing that you're listening, especially if they're frustrated because they can't get the words out or they can't get the communication out, can help them by saying, I am really trying hard to listen to what it is that you need in this moment. Mm-hmm. Reflecting. So that person with dementia tells me something, and I reflect back in my own words what I heard from them. Again, to tell them, I heard what you said, and I heard what you need. Using a name. When I started working with older adults, I was always told, you should call that person Mrs. or Mr. Really, the person, if they're still able to tell you what they like to be referred to, you should ask, and if they're able to say, no, I like Mrs. or Mr., or just call me by my first name, that of course is the best thing. the optimal situation. But at some point, when you meet people, they may not be able to tell you anymore what they prefer to be called. And so one thing that I think is really important about this is women who have taken on their husband's last name. If you call them Mrs. Karno, and that's their husband's last name,
Right.
They may not respond to that anymore, because that's
Short-term.
that's a long-term memory of the name that they don't have anymore, and sometimes it is actually better to refer to them as their first name. Now, men, it may be a little bit different because they're always called their last name.
Or like a nickname, sometimes it's a good question, I'll ask families like a nickname from their childhood, like Tootsie or, something like that. That can be very helpful too, is what people used to call them from back in the day.
Well, a really important one too is like
Yeah.
my mom stopped responding to mom a long time ago.
Oh, that's,
But it's
yes.
so hard to break that habit.
Oh,
Just
sure.
Calling your
By
mom.
her name.
By her
Call her by her first name.
Yeah,
Yeah,
because the
it doesn't
caretakers that she's with, that's what they call her.
That's what she relates to now.
But there's an emotional piece tied to that.
Oh,
Like, oh my
sure.
God, my mom doesn't respond to
Ugh.
mom anymore. I have to call her by her name. I've never done that before.
That's tough.
That's hard. Using eye contact and touch when appropriate. Now, it sounds like the people either that you love or that you work with, you probably know how they respond to touch. But when we do training with people that are not sure at first, because they've just met that person, to just be very careful with touch.
Yes.
Because I would say, for probably 80% of people with dementia, I mean, they don't get enough touch, and they're starved for touch.
Yes.
But you might find that one person where touch really sets them off, and so you have to experiment a little bit. And the way I teach to do that is I'll say, reach out your hand to that person. Hi, I'm Deena. What is your name? And if they reach and shake your hand, then that may be a good indication that they don't mind having touch, and kind of go from there. Don't talk over that person, talk to. And don't talk about a person with dementia to somebody else while they're standing there, because again, it's all about how they perceive that interaction. And if they're able to perceive that interaction as they're talking about me, not asking me, not to me, they may just get agitated and push back. Yeah. Speak, of course, gently and clearly in your tone. Ask one question at a time. Use simple sentences and questions. If you're with this person and day in and day out, obviously you're going to experiment and see what works the best. But if you're meeting somebody new for the first time, you may have to, again, like I said, experiment in terms of, am I able to say a few directions at once in one sentence, or do I have to really break it down? Like if I'm helping them get dressed, do I have to say, okay, put your arm through the sleeve, instead of go ahead and put this shirt on, put it over your head first, and then put your arms through the sleeve, and really break that message down. Sometimes explaining or showing what you're doing can be very helpful. So let's say I want someone to drink something. I want to encourage them to take fluids in. So not just saying, okay, why don't you go ahead and pick up the cup and take a drink? They may not be able to make sense of that. So sometimes I'll say something like, okay, go ahead and take a drink, and actually gesture it, because they may acknowledge that gesture better than they acknowledge those words. So whenever you can gesture, that's always good if that person is not picking up on the words. Breaking message into parts, and waiting for a response, which I think is really important to talk about, because when we are in regular conversation with someone who doesn't have dementia, usually people respond right away, right? So we're so used to that in conversation. But sometimes it's not that a person with dementia can't respond, it's just that their brain takes a little bit longer to process the information, and then we move on. And now we've answered for them or guessed what they're going to say, and we haven't given them the ability to tell us what they want to say. And again, it's setting it up for them to get agitated and mad because we're not allowing them to have that time.
Any questions? I think too, looking at the techniques when we were preparing the slide, like the ones like I feel comfortable with and ones I'm good at, but also recognizing the ones that you could work on. Like for me at work, when like I'm ready to take someone to lunch and they're in a wheelchair, sometimes I'll just unlock the wheelchair and I'll take them, and I'm not even telling them where I'm taking them. You know, like definitely, and that's not good, but it is something that I know that I have to pay attention to, because I am so quick paced that sometimes I have to slow down, get to their eye level and say, I'm going to take you to lunch. Like sometimes you have to remind yourself to cue them what you're doing, because to us it's a natural response just to take someone, you know. So just to kind of verbalize to them what you're doing can make them feel more comfortable.
I find times when we go out for dinner, let's say with another couple, and it seems like conversation is very rapid fire, and I find that Charlie just tends to sit there and listen more than participate.
Yeah.
And, you know, I feel bad with that. I guess going forward, I need to tell these people, you just need to slow it down or engage or ask him the specific questions. But rarely is he, you know, jumping in. It's usually, I'm usually so starved for conversation.
Sure.
Yeah.
Well, and it may be also because when you're at a restaurant, a lot of times, if there's a lot of people in the restaurant, there's a lot of loud conversation going on in back, and it can be hard to separate what the people you're with are saying versus what you're hearing around you. I even have that trouble sometimes when it's really loud. So yeah, because the more stimulation you've got going on, you know, people walking around, noises going on, that can hamper with being able to understand. Yeah.
These days it seems like people speak quickly, and I think they're speaking very slowly.
Oh, absolutely. Which I have to remind myself
of.
I do. Yeah. Yeah.
My kids do that all the time. They talk, you're right, they talk very fast and you say, I don't know what you just said, repeat it. And then they'll do it again really fast. I say, slow it down.
Sure. And you can kind of, I mean, pay attention to their facial expressions and their body language, because I do think that's a way to see if they're catching on, because sometimes you can see in their face if they're not catching on. You know, pay attention to the body in those interactions.
The other thing I was trying to do to just sort of give Charlie something to do was like do book-ups on tape. And he did one, and he just doesn't seem interested in them again. Is that hard for folks with dementia to listen? And
So I get told a lot that people who used to read the newspaper every morning will all of a sudden just be staring at the newspaper, and you know, they're like, but they know how to do it. They've been doing it their whole lives. Sometimes I think, or watching TV, that it's actually not going in. So if you are seeing that, maybe I would try something more tangible that he could see, like adult coloring books, you know, are all the rage, where they can actually connect the hand to the paper. Because if they're not necessarily just hearing it and seeing it, it might just be too open. So maybe try that. But yeah, that I've heard that.
So yeah, TV might be better. And the other thing that occurs to me is to understand books on tape, you have to be able to have the focus for that, and to have to be able to remember what came before, whether it's, you know, you're learning something new or it's a story. And if you can't connect the facts that you're hearing in that moment to what you heard before, then it probably becomes very uninteresting. Yeah.
Maybe music.
Yeah.
With headphones.
Oh yes, he likes that.
Instead of just, that might be easy.
Things like, you know, we bought puzzles and Scrabble and doing all these things, and I just can't get him interested in doing it. And I don't know if it's because he never really did puzzles and it's new to him, or if he's still looking at it as, oh my God, this is what people with dementia do, and I'm not quite there.
Are you doing it with them?
My kids were.
Okay.
And he wouldn't even, he was like, nah. So now my kids are doing puzzles, but.
Right.
You know, I don't know if this is an option, but there are websites for brain games.
Oh, yeah.
We tried that, like Luminosity and, on the computer, and then the computer's too hard for him now, so.
Even a tablet? Would a tablet where you touch the screen?
You only do the technologies I bought.
Sometimes that's why getting someone involved in the day program, I mean, I'm not just promoting us within, but when you put a group of people together who aren't family members telling you what to do, there's a different level of willingness to participate when it feels like a social club versus, you know,
he does go to a day program, and again, I think he's like, because he's probably one of the youngest, and he's only.
Oh, sure.
68. So, I mean, I think he
Feels-
a lot of ways, I
he
think
can
he
tell.
sees his future.
Oh, for
and
sure.
So it's.
Sometimes, and I would be happy to go over this more
Yeah.
with you in private, but telling them that they're volunteering at a certain
Yeah.
place, put,
So it's creative.
no, I'm telling you, you have to get creative. I've seen early onset is really tough because they can tell, and that's why that volunteer piece does
Yeah.
sometimes help. You're giving back,
Yeah.
and then
exactly.
then they think I'm
Yeah.
you know.
I know.
So, yeah.
I'm going to forward to the next slide.
go
Okay.
ahead.
There's a lot of overlap in what we just talked about on the last slide and this, but there are a few things that I want to point out. Remember that your mood will be mirrored.
Yes.
This is true for not just people with dementia, but all of us. So I think about being at home. My husband had a bad day at work. He comes home. You know, maybe I'm in a good mood. My day went fine. He comes home. He's in a bad mood, and he's kind of huffing and puffing around the house. Don't we tend to take the moods on of those people around us, especially the people that we love, because we feel bad that they've had a bad time or a bad day? And so just remember that somebody with dementia, that's still going to happen. So now, can you be in a good mood all the time? Absolutely not. You have a right to your feelings as well and to experience your feelings. But to just be mindful of the fact that whatever mood you're in, likely that person is going to mirror that back to you, because that's the vibe and that's the feel that they're getting from you. So as best as you can, especially in moments where maybe they're already agitated already, to try to make sure that you are not portraying, you know, a negative type of mood to them, because that could become a problem. And then I think the last one that I want to talk about is using humor.
Which you guys mentioned.
that can be good to try to interject humor whenever you can into conversation or into interaction.
I mean, if they say something funny and you laugh, it's the intention. You're not mocking them. I mean, laughter is a part of human nature. Feel free to do it. Feel free to use it.
My mom will always laugh whenever anybody else is laughing. She just joins in on the
Yes,
She
it's
has
there.
No idea, absolutely
No
idea.
idea,
what's going on.
but it's in her soul. It's
Right,
still
that's what I
there.
say. We have to go there and just
Laugh.
and play music, and then she's like, you know.
Yes.
Yeah, it's so
But when
strange.
you laugh, I mean, all of us, when we laugh or we smile, even if we're in a bad mood, I mean, even in that moment, it's a feeling of well-being. It can.
Yes, endorphins, absolutely.
Exactly.
There's like
And
a whole
so-
thing called laugh therapy now.
Laughter yoga, I think it's called.
Yeah.
Which I've done before, and it's a little strange, but I was in a group once when we did it, and it's a little strange, but no, you get that feeling that lifts you up a little bit, and so to try to interject humor, just remember, we're trying to strive to make as many moments as meaningful for that person with dementia, because especially when they're really in those mid stages to later stages, that's all they have is that moment. They don't have, a lot of times, the past. Sometimes they're remembering the past, of course, but many times they're just in that moment. And so to try to provide as many opportunities for feeling good in the moment and making those moments meaningful.
Yeah, that'd be great. Oh, you want to do this one?
Yeah, so we just go ahead and read, we're going to read a case to you. And then we want to ask you a little bit about how you might respond in this situation.
Okay, so Bessie is a 93-year-old resident that refuses to go to lunch because she insists that her mother, 93 years old, her mother is coming to pick her up for lunch. You obviously know that Bessie's mother is no longer living. But you also know that she's, if she doesn't eat, Bessie will be hungry later in the afternoon if she doesn't go to the lunch, right? So what would you do in this situation? Go ahead and then go ahead.
I'd say, we're meeting your mom at the table.
Yeah.
By the time you get to the table, they have no idea that they said they were meeting their mom.
Great.
I was thinking of a little fib too. Oh, she called, she's going to be late. She wants you to have lunch before she gets here.
Great.
And she'll forget.
That's not
Yeah.
my girl, actually.
That is the little fib that you were talking about.
Exactly. Segue right
And
into
it takes
it.
a long
Any
time
other
to
one?
realize that you can do that and it makes a difference.
Yes, and that's
Very hard.
I recently just moved a family, and when I told them about the therapeutic fib, I like set them all off. Like they were so upset with me. What do you mean you lie? I mean, because I'm saying,
It's okay.
yeah, I'm telling you to lie to your loved ones, but and she'll go into it, but the intention is that it's therapeutic. So that's why we try and teach this. Yeah.
I was listening to NPR, and there was a comedian, and he was at home a lot, his wife worked, and he was there with his mother-in-law, and he really liked his mother-in-law, but she had dementia. And she would say, well, there's an elephant walking down the street. He said, oh, come on now, there's no elephant there. Finally, this little light went on, he said, yeah, there is, and it's pink.
Right.
Went on and on. Well, he was very entertaining to begin with.
Yeah.
And he, time after time after time, all the things he would, and they had this fabulous communication.
Yeah. Brings them up. Go ahead.
Well, remember that when someone tells you something that seems so crazy like that, remember that sometimes they are resorting back to memories that they've had in the past. So this woman may have seen either in a movie or in real life an elephant walking down the street, and now that memory is coming into her head again and she's reliving it, and she tells somebody and it's, oh my God, there's no elephant, that's crazy, Right. But remember, people will go back in the past and relive memories that they've had, especially if they have those memories that have a lot of emotion tied to them. That's the ones that we tend to remember better in dementia, because that part of the brain that regulates emotion can still be preserved. And so those memories that have a lot of emotional meaning may come up.
Aren't hallucinations part of this?
Can be.
Sure.
Delusions. So delusions is a fixated thought that is not reality-based. But to that person, it's reality. Or hallucination, seeing, tasting, hearing, feeling things that are not truly there around them.
My husband is in a home, but sometimes he has some delusions. And one of them was, he's a doctor. He's a general internist. I've got to see my patients.
Oh, yes.
I've got to see my patients. What am I going to do? And they do the therapeutic lives.
Yeah.
You have other doctors who are taking your practice now, and they are taking care of that patient, and the patient is doing well. And he is just
He's fine.
So there's usually, I try to train the staff, there's usually, like she said, there's an emotional piece in these situations that they're trying to get at. Like normally if someone's looking for their mother, it's because they want to be comforted. Or if they're looking for a patient because they want to make sure that this patient is being taken care of. So if you can get to that emotion that they're trying to express to you to help calm them down in their reality, that's what I train the staff at. It's never no, you don't have a patient, or no, your mother's no longer living. There's a feeling there that they want to express, and our job as the caregivers to try and get to that feeling.
So if we could go to the next slide. So we wanted to pose that case to you to see what you would say, because there are 3 over the course of time approaches that in working with people with dementia that we've developed. We always ask the question, should I validate, fib, or reorient? So in the beginning, we thought that when someone is not in reality, that what it was best was to tell them what reality was.
Right.
And certainly in...
Excuse me, is that reorient?
Reorient, yes, reorienting. So certainly, as you were talking about in those beginning stages, when they still may have some insight and understanding, that's a little more dicey. Do I reorient them? Do I not reorient them? As they get to the later stages, though, reorienting usually is either going to cause you an argument or it's going to re-traumatize. So,
sorry, what's reorienting? Telling them this is reality.
Yeah, like her. So if someone comes up to me, which this happens very frequently in memory care or nursing home, I need to find my mother. And we think it's maybe because hopefully your mother represented to you nurturing, familiar, you know, and so maybe what they're communicating to us, it could be that they actually physically want to see their mother, but a lot of times we think it means that person, it just feels like everything's unfamiliar, and things just feel anxiety producing, and they want that comfort of what their mother has represented to them in the past. So we think that's sometimes what they're saying. Same thing with home. You'll see a lot of people that will say, I want to go home. I want to go home. I want to go home. Now, are they picturing their home that they used to live in on whatever street?
Right.
Possibly, that is possible. But sometimes we think they're communicating, I don't feel like I'm in a familiar place. You know, your home is where you kind of let it all hang out and you're comfortable, and so sometimes we think that they're communicating by saying that I just don't feel like anything around me is familiar. This just feels bad to me. So reorienting at certain point will have no payoff whatsoever, because you're either going to re-traumatize them when you tell them that they're 84 years old and their mother died, and they don't remember that, and my mother died? When did she die? And you were traumatizing them, or that person's not going to believe you and say, my mother did not die, I want my mother, now find her for me right now. So reorienting at some point is not something that we advocate to do at all. Then you've got a therapeutic fib, which all of you gave examples of what you might do. But I even like something called validation better. And this has to do with what Jackie was speaking to, the underlying feeling and getting to that underlying feeling. So if someone comes up to me and says, I want my mother, please find me my mother, likely they're communicating something to me, not just that they want their mother. And so it's upon us to try to be, I guess, a detective in some way to sort of figure out maybe what that feeling is. So what I always like to do is, if someone says that to me, is I'll say, wow, it really seems like you're thinking about your mother a lot. Tell me about your mother, and see if maybe they can expand a little bit on telling me some details about their mother, and then say something like, it seems like, you know, you and your mother were close, or you and your mother did this together, and I'm sensing that maybe you're not feeling so comfortable right now, like things aren't familiar to you. And see if you're right about that. See if the feeling, when they're describing that you're getting from them, and naming that feeling, and that may just very much diffuse the situation and distract them and redirect them into. So I always like to say, let's try to acknowledge that feeling, because if I therapeutically fib, I'm just kind of glossing over it and I'm not acknowledging what's going on. Now, someone may come up to me and say, I want my mother, tell me about my mother, and I'll start to, you know, very lovingly try to say, tell me about your mother. I don't want to tell you about my mother, I want my mother, find my mother for me. And they're not kind of buying into it. And so that's where I would say, then let's move to a therapeutic fib. Therapeutic fibs, I just caution you, because often people don't remember what you've told them. You know, your mom went shopping and she's coming back later, or, you know, she's going to be at the table. But sometimes they will remember, and then when they catch you in a lie, you're in trouble, because you don't have that trust with them. And so I always advocate to try to, what we call, validate first, and then if that doesn't work, then move on to a therapeutic fib.
I appreciate the idea that you had about, tell me about your mother, and I don't want to tell you about my mother, just help me find her.
Right.
Sometimes it's because they can't verbalize any more about it. They don't
So
have
sometimes you ask not yes or no questions. Were your mom and you close? They can say yes or no. Did your mom and you spend a lot of time together? Yes or no. And so you know, all in asking those questions, though, trying to sense whatever feeling that is.
I like your idea of movement. It's like, is this your mom to you?
Yeah. And if you're comfortable with, I mean, I was gonna say, if you're comfortable with touch, sometimes like, do you need a hug? Or like, I'll put my hand out while we're walking, they'll just like grab my hand. I mean, usually they're looking for some sort of comfort in those moments.
So
and I rub your back.
I see that we only have about 5 minutes left, so can we forward to this? Go ahead.
We have some options too. If people want to have lunch in like 10 after noon, we could do that. We could also eat as they talk and they don't get to eat.
Or if you're done with us, you could tell us too, I mean.
What's the group?
Or you could have lunch and have it like a Q&A during lunch.
Sure, we would be happy.
Sure.
You know, so that everyone could eat.
I'm sorry, Lois?
I need to leave at 12:30.
Yes, and I think at least one other person also needs to leave a little early.
We are here for you.
You haven't covered that is really important for us to hear?
Yeah, you've got 1, 2,
Well,
3, 4, 5, 6,
Yeah, so
7, 8
there are
slides.
two.
More important than nothing.
There are 2 slides that I think
Go,
are
no, no.
important. So if you could advance to, it looks like this one. So this picture is not just of an older adult. This is someone named Naomi File. And she is a social worker by training. And she was the one that came up with this idea of validation. She has books to read, and they're great. So you may read some of her books about validation. She also, I mean, this isn't something probably anyone would invest in, but she also has a very expensive training program that people can get trained to do validation, which I've never seen before, but supposedly when people get trained to do this type of validation approach, and they do groups with people with dementia, some pretty amazing things happen. People start to talk about things that you don't think they're capable of talking about anymore.
Could you spell her last name?
It's Feil. She may even have on YouTube some videos. A second person to mention that has YouTube videos that is really good for caregivers, her name is Teepa Snow. It's Teepa and Snow, just like the word snow. She's an occupational therapist by training, and she actually goes around the country talking to mostly people that work with people with dementia, training them and also on how to work better with people with dementia. She's got a lot of free YouTube videos.
Big following.
Yeah, and she's got her own website with good tools and information on it as well, and she's very, very good. You'll see in some of her videos that she'll do some role plays. She'll do some role plays and actually act like the person with dementia and have somebody else navigate how that interaction so that they learn better how to work with people with dementia. So they're both very, very good resources. Validation is huge, though. It's not just sensing the feeling. There's a lot more to it, and I've never been through the validation training, so I can't say that I even know, 25% of what it's all about. But some of the takeaways from it that are easy to use are rephrasing things, using key words. So again, mirroring back to that person what they've said can feel very good to that person with dementia because they're validated. Reminiscing and exploring the past, talking about things that have happened in the past, if that person is able to do it, can be very therapeutic for that person. Using touch if appropriate, making direct eye contact and using a loving voice. Observe an emotion and match it. So if you're telling me, if the person with dementia is telling me something that's sad, I mirror that sad look, because what is that, again, communicating to that person with dementia? That I'm sitting with you and I'm really trying my best to understand what you're feeling and what it feels like. And one thing that's a big one is sing old familiar tunes, because again, it speaks to that part of the brain that is still able and preserved to be able to enjoy music and associate with music. The other piece of it that I don't have on this slide is a great example of what you gave about the elephant and the comedian talking about the elephant. That instead of challenging somebody's reality and saying, there's no elephant walking around down the street, stepping into their reality, as long as it's safe, it's a safe thing, and just kind of going along with it and playing along with it. It's a way for you to connect with them. And you may find from that interaction some understanding of why it is that they did bring up this memory, or they did bring up what they're thinking about. So we always say, step into that person's reality and don't challenge it. The other slide that I think is really important is the self-care slide. So if we can forward to that one, and then definitely we're here for questions.
We could start with that one first. I mean, I think, does anybody want to call out any challenges that aren't on here or that you relate to the most of being a caregiver? We've got overwhelm, sleeplessness, fatigue, exhaustion, lonely, right? These are, yeah.
I think perhaps the lack of your family's support.
Oh, sure.
As a caregiver.
Oh, yeah.
Thinking,
Not everybody
why
gets
aren't
it.
you doing anything to help me?
Oh, and don't you love it when they tell you what to do too? Right? They give you all the advice, yeah. Any others?
When my father's vascular dementia went ahead, he became very fearful.
Sure, yeah. Like paranoia
And he
fear?
didn't want my mother away from him for more than a minute.
Codependency happens? Yeah. And then what does that do to the other person who has to be?
Well, as a caregiver, I don't know how she survived.
Right. Yeah,
She
it
and
can
I
take
went
you
out
down
shopping
too.
one day, and I had my husband stay with my father. He was a wreck when he got home. 'Cause
Sure.
he was just so needy, and he
Yeah.
was so agitated, and so.
Yeah, that's an interesting thing to do. If anybody questions your ability, say, okay, then you be with them for 3 hours. That 3 hours, you'll be going, oh my God, you're a saint. I can't believe it. You know, I do that with my boys, my girl boys. Yeah, and they're like, oh my God, you know, and, but yeah.
Marcia, I had another church I worked at, I had somebody come in to talk to church members about that specific issue. And here was their advice. Sit down and have the talk. And get a commitment. What you can do and what you can't do.
I like
so
that.
you just know. And if someone says, you know, I'm just, you know, maybe I can do something once a month, or I can do this one specific thing, but I really can't do anything else, then you know what they can do and what they can't do. You get them to verbalize it in a group setting so that you're not guessing, and it takes a little bit of the resentment out of it. Well, at least
I'd like to do
because
something once a month, but
right.
Because
usually
tapped out altogether.
Sure.
We're never going there again.
Sure.
Because this is usually about siblings talking about care for aging parents.
Yeah.
And it's usually not equal.
No.
There's
usually never.
Never. And just to get it out on the table, like who's gonna take the lead
Yep.
on finances, who's gonna take, on
Healthcare.
getting home health care, or
Yeah.
whatever it is, having the conversation was their major point. But part of that then is realizing that it's not gonna be equal, and just getting that verbalized.
I like that.
I think the one thing that was important in our household to have a conversation about, and it was really myself with my 2 boys, is because my one son is like, Mom, you don't ever have to worry about it. If something happens to you, I will move in, I will take care of Dad, I'll do that. And I'm like, no, you won't. Here's what I want you to do. You know, there's plenty of money, you've got everything at you, but you're a young man, you can't step in and do that, and don't think you can do it, and I don't want you to do it, and Dad wouldn't want you to do it. So I think it kind of goes both ways of I think they can jump in, and he always thinks he can take care of me, and it's like, we're all gonna figure this out, one day at a time, but it is interesting how my 2 boys have a different approach to me, different approach to their dad, and just how they all handle it. It's interesting to step back and watch that a little bit. Yeah.
Good family
Is
dynamics.
there something called sundowner syndrome?
Oh,
My
yes.
father became very agitated late in the afternoon.
Yes, I'm sorry.
To get him to bed was horrible.
Yeah,
We kinda skipped over it,
Yeah,
but-
we skipped a little bit over talking about some of the behaviors that you see, just because of the sake of time. But yeah, sundowning is not something that happens to everybody with dementia, but a fair amount of people, where you find as it gets later in the afternoon, sort of timed a little bit with, we think, as the sun goes down, that people get either much more confused or much more agitated or both. So, you know, what you're used the conversation you might have with them in the morning versus the conversation they're able to have in the evening may fluctuate very much. And we don't exactly know why this happens. They say it could have something to do with, and I don't understand circadian rhythm, it's like our body's clock, but that the body's clock is off and with dementia, and so later in the afternoon, you know, this whole circadian rhythm is messed up, and that's why we see this. Maybe it's, you know, all of us, as the afternoon comes on, we get more fatigued. I mean, it's just, as time goes on, we've used up energy, and we don't know why for sure.
It's too bad it's almost 12 o'clock that I suddenly realized to bring this up. I've been curious about the researches they've been doing in places like Norway, northern Norway.
With all the communities?
Light
therapy.
And all, helping to prevent, and they have cataloged that it really does work, preventing suicide and depression. And it sort of verifies, you know, just this morning they were talking on the radio about winter slump. You know, and now
seasonal
people get
depression.
more cheerful. And has any of this therapy been involved in light, just in everyday light things?
I don't know a lot about that.
Could that be pursued?
I don't know a lot about light therapy. It definitely makes sense to me. I definitely see seasonal depression happen at the Friends Center where it gets darker earlier, and then the sundowning piece. I definitely see people's moods shift based off of time of day and light, so that absolutely makes sense to me. I'm not that familiar with
The kind of
it.
light they're using seems to be a particular kind
Sure.
of light, and I think that's...
You can buy lights, so for people that
depression.
have seasonal affective disorder, you
Yeah.
can buy a light, and there's a
It's the
prescribed...
kind of light that makes a difference.
Yes.
Yeah, there's a
For sure.
prescribed number of minutes every day that you sit under it, and it's supposed to help with the seasonal affective
Would
disorder.
you like to touch on the last slide while I get the food out?
Sure. I mean, of course, the most important thing should be self-care, and I feel bad that we have only a couple minutes left to talk about it, but if there's anything from this whole thing that I think's important, and I don't know if you agree with me or not, is self-care for your caregivers, or else you will burn out. And even someone who knows this in my own life and in my own counseling techniques, I have to pay attention to my body because I will carry all 40 residents' problems in my body and I will take them home with me, and then I cannot be a good therapist, I cannot be a good wife. We'll see how I am as a parent, we'll find out. Who knows? But this to me is very important. These are techniques you can find off the internet. I mean, they say, remind yourself that your work has value, what you're doing has value, right? Join a support group. Nurture the positive relationships in your life. I also think it's important too, if you, on the opposite end, if people are inviting you out to lunches and couples and this and that, and you don't want to go, don't go. Yeah. Right? Like, you don't always, they always say, you like, plan these dates, but it's also okay to say no if you don't want to, okay? I'm giving you permission. Give yourself a break. Don't forget to take care of your own health, right? Eat healthy and exercise. Unfortunately, we see a lot in my support group that if the caregiver isn't taking care of themselves, that they may go down quicker than the person who's diagnosed. Okay? So you have to take care of yourself.
Yeah, there's a lot of research about it. No, just to say, there's a lot of research about that.
I see it.
Often a caregiver will end up dying first before the person that they're caring for because they're completely focused on that person and not focused on themselves at all.
I see it all the time, unfortunately. Yeah.
I used to lecture about that.
You did? And what'd you say?
The caregiver has got to take care of
You
the caregiver.
have to.
And when this happened to me, and I was awake for 24 hours a day, I finally realized that I had to take care of myself, or I would not be around anymore to take care of him.
Right.
You equate it with when you're on an airplane and they say if you're sitting next to a young child, make sure you, in the, you know, it pressurizes, make sure that you put the mask on yourself first so that you don't pass out, and then you can put the mask on the child or whoever needs it.
Do you guys have any other techniques you want to share with the group? And by the way, it doesn't, I think nowadays everyone uses this phrase, self-care. It has to be like a huge thing, you know, like get a manicure or get a massage, or those are definitely techniques, but it could also just even be 5 minutes to meditate. It doesn't have to be.
Maybe try to get rid of some of the guilt.
Yeah.
That's hard.
Ooh, yeah.
Going to a support group, yep.
Yep.
Well, we kind of use my mom as like a confessional, so.
I love that.
Yes, it's like,
You can't tell. Drop all those secrets.
I confess, like, oh,
Yeah.
I smoke pot and, you know. It's like, okay, I just like cleared my whole, you know.
Sure.
Or just tell her things, they're like, you really hurt me when you did this.
Sure.
You know, in 7th grade or whatever.
Let it out.
Yeah, and, yeah. It's really kind of funny, but, you know, because she just sits there and she doesn't say anything, so it's like, okay, I'll just keep talking. It's like, but anyway, that's how I convinced my brother to go, because he wasn't going anymore either. I'm like, just go and confess, you'll feel better.
Sure. It's a good technique.
Pretend she's a Freudian therapist.
There's just
Well,
one, can I just
yes,
mention one last thing?
yes, please.
Some of them are expensive, of course, but don't
Right.
forget that programs like adult day services exist, and depending on your finances and need, there may be state money that can reimburse for that, so you could always look into that. And again, it's expensive, but even lots of nursing homes or memory care units, assisted livings will do what they call a respite stay.
great.
So, you know, if you just have to
Great.
have some time to yourself and you're burnt out, that could be an option.
The North Shore Senior Center, House of Welcome.
Yes.
I'm sure you're aware of that.
Yes, yes.
I mean, that's not sleepover.
No.
But it is hours to be free.
Yes, but there are places, like my place, if I have a room open and I have a couple weeks availability, that you can move your loved one in for a couple weeks. And that's what she needs, or a couple, even for 2 days. If there's a room available, I mean, you pay, but it's like, then you can get.
You know they're safe.
And then there's a nurse, and they can give the medications. That's
And
a
most
great.
of the time, if they go there, they're so happy there.
Sure.
that They just stay. Yeah.
I want to thank you all for being here today, including those who are watching at home. This video will be available with the PowerPoint in a couple days. Also, remember to always feel free to contact Carol or me in terms of care and calling, and our newest care and calling volunteer, Linda Hoffman. I was kidding, but apparently not.
Yeah, that's great.
Yeah, we are here for you, and we can always also direct you to other referrals, including the Gidwitz Center, the Weinberg Community, and Deena and Jackie. Thank you, Deena and Jackie, for being here today. This was a high-energy, high-impactful event. And now, lunch.
Yay!
It is behind you. Eat your fill, because there's a lot over there. And will you be able to stay with us?
Yeah,
for
a little while.
For lunch anyway?
bit.
Okay, and hope you get some food.
Sure.
All right.
Thank you. Thank you.
Boy or girl? Boy or girl?
Boy, my first.
First child?
Yeah.
Oh,
First child.
It won't stay.
Oh, please. Yes.
Oh, shit. It's like, I'm like, what is up, people?